All right, it's a real pleasure to be here. I want to thank the course organizers. I am charged with speaking about after the tricuspid valve, the cardiac shunts that you can see, specifically ventricular septal defects and patent ductus arteriosus. Now, I have no financial disclosures, but I will say that I am a big fan of Dr. Huie Lin. You know, he's a clinician and a scholar and a friend, and to know him is to love him, and to love, well, you get the point. But, you know, the reality is my only complaint with Huie is that, again, he put me between Sabrina Phillips and Ami Butt, so I'm going to do my best to keep you guys entertained, but you got the excitement before and after coming up. So during this lecture, we're going to be talking about the anatomic classifications of ventricular septal defects. We're talking about how VSDs clinically present and indications for VSD closure. And then we're going to spend just a few minutes talking about patent ductus arteriosus, both the clinical indications and when you think about closing those. So VSDs are fairly common. About 20% of our CHDs in children are VSDs in isolation, though very often VSDs are part of a congenital complex. They come with a lot of other congenital heart conditions, such as, for example, tetralogy of Fallot. We often think about VSDs based on where they're located anatomically in the ventricular septum. So the most common form of ventricular septal defect is a membranous VSD. That's about 80%, and that's located in the ventricular septum. If you look at the color here at yellow on the diagram, that's right between the aortic valve and close to the tricuspid valve. The second most common is a muscular defect. Now, the muscular ventricular septum is the majority of the ventricular septum. It contains the majority of the contractile muscle in the ventricles, and it's about 10 to 15% of VSDs. Outlet VSDs are about 5 to 7%. They are that part of the ventricle which is between the aortic valve and the pulmonary valve. This becomes important, all these specific locations, because they lead to different sets of complications depending on where they're located anatomically. Now, outlet defects are not that common in the Western Hemisphere, though out in the Far East, they're a much higher percentage in incidence. And then finally, inlet VSDs, which you heard a little bit about being part of the AVSD complex, and you'll hear from Dr. Bott in a little bit. That's where the ventricular septum, which is right at the crux of the heart, where the AV valves insert. Part of the confusion in congenital heart disease in general, and part of the issue with VSDs, and you know, if you all know the allegory from the Bible of the Tower of Babel, well, you know, we use a lot of different terms to say almost exactly the same thing, though people will swear, oh, definitely a conal VSD is different than an infundibular VSD, and definitely a doubly committed is different than a supracrystal or an infracrystal. But the reality is we often interchange these words back and forth, and it just confuses the heck out of everybody. And so you have to know a little bit when you're dealing with congenital heart disease. Be comfortable with our alphabet soup of how we talk about different lesions. And these 4 different lesions, and these terms are thrown around, but you should know them. Now, VSDs in general are very common. They are the most common, you know, ASDs being the second, but the most common form of congenital heart disease, simple congenital heart disease, if you exclude bicuspid aortic valves out of the equation. But in adults, they're a lot less prevalent, and that's because that a lot of them actually self-close. Up to 75 or 80% of the smaller or medium VSDs will close on their own, and there are some that in isolation will stay open, especially the larger ones. And so when we try to define where they are anatomically, echo is our gold standard, and I will show you a little bit of echo, a little bit of MRI, and a little bit of cath to give you a flavor of some different imaging modalities. But in echo, you can really distinguish the anatomic subtypes, so whether it's membranous, muscular, outlet, and inlet. And I won't go into the details of which views you see, which parts of the septum, but certainly it is our standard to look. When you think about the physiology of a VSD, well, it's very simply put, it's causing a left to right shunt, but unlike an ASD, which is before the tricuspid valve, that left to right shunt, generally the volume load happens, it happens during systole, and so it gets pushed out the ventricle right away, and so most of your ventricular problem is actually on the left ventricular side and the pulmonary arteries, and that's an important distinction from anomalous veins and from ASDs. But the hemodynamic significance is based on 1, the size of the VSD, a larger VSD, more flow. Second, the relative ventricular pressures between the RV and the LV, and just as importantly as ventricular pressures is the resistance and the pressures in the pulmonary circulation versus the systemic circulation. Now, as I was alluding to, different anatomic types of VSDs cause different problems. Well, membranous VSDs are close to the tricuspid valve, so that tricuspid septal leaflet can get sucked in, sometimes actually helping to close the VSD, but that can lead to secondary tricuspid regurgitation. Versus an outlet VSD, which is close to the pulmonary valve and the aortic valve, that can sometimes cause aortic valve prolapse, leading to aortic regurgitation. And so that's where that anatomic distinction becomes important. The clinical consequences range from being asymptomatic all the way to having really significant symptoms. And again, a very small restrictive VSD, you may not notice anything until later in life. You may get gradual left atrial LV dilation over time. And again, this is one of the questions on your CME questioning. It does not generally classically cause RV dilatation, though we all know that it can, but it doesn't typically do that you think about it from a physiologic standpoint. A large VSD, a non-restrictive VSD, if you don't deal with that early in life, will cause pulmonary hypertension and can lead to a phenomenon we know as Eisenmenger syndrome, where you get right to left shunting, and that can be a bigger problem, which is why a large VSD, which is causing symptoms, you often talk about closing early in life. Okay. On physical exam, VSD generally will cause a harsh systolic murmur. The smaller and the tighter the VSD, the louder the murmur. A large non-restrictive VSD will, if it comes to the point that the PA pressures are higher than the LV and the systemic pressures, you're going to get reversal of shunting going right to left, and thus you start getting deoxygenated blood going into the systemic circulation. You can get cyanosis, clubbing, and you can actually lose the murmur. From a study standpoint, as far as our basics of chest X-ray and EKG, you can see signs and the early stages of left heart dilatation and cardiomegaly, both on chest X-ray and EKG. And if you do pulmonary hypertension, you'll get pH changes on your imaging. So people often ask, how do you figure out, based on size, whether it's small, medium, or large? And I put out numbers there, but I'll say that there is really no clear standard for small, medium, large. It's more the physiologic effects than the numbers. But we often look at the VSD size relative to the aortic annulus. Why? Because a 4 millimeter defect is very different in a 3 kilogram baby than a 70 kilogram male. And so the relative size of the VSD to the aortic annulus is what we look at. But just as importantly is the degree of gradients and whether the degree of shunting that you see, the physiologic effects. Okay. To talk a little bit about the subtypes and go through. So membranous, this is, if you looked at it in a parasternal long axis view on echo, it'll often be that part of the ventricular septum right next to the aortic valve, kind of tapered towards the tricuspid valve. They can close, as I mentioned, with tricuspid valve tissue, and if you do need to close it, and we'll talk about indications in a second, surgery is your standard and your gold standard way to close membranous VSDs. Percutaneous closure is done occasionally, though it is very off-label, but we do it on certain case-by-case basis when there is a ventricular septal aneurysm. So this is a parasternal short-axis view of an echo clip. You're seeing the aortic valve in the middle, and you're seeing a tricuspid valve on the left of the screen, and you're seeing a membranous ventricular septal defect. That's often the location. The gradient is high. It's about 95, so this is a restrictive membranous VSD in an adult who we are just watching and not really doing anything. The patient doesn't have left heart dilatation and is asymptomatic. This is a separate patient with a membranous VSD. Again, closer that you're seeing it in an apical 5-chamber view, where you're seeing left to right shunting, and when you're tapering up towards the aortic valve. Outlet VSDs, now that same parasternal short axis where you saw the membranous defect, if you look actually from 12 o'clock to 3 o'clock where the pulmonary valve is, that's the location where we look for outlet ventricular septal defects. They are a little bit more risque, if you will, in that they can involve the aortic valve. And in general, the aortic valve regurgitation is a slightly more pressing problem than tricuspid regurg, though both are important. But from the standpoint of, we think about being more proactive when you see a outlet VSD that's starting to affect the aortic valve in considering closure. And again, closure is a surgical closure for these types of VSDs. Just to tell you a different modality, this is an MRI of a patient with a outlet VSD. This is sort of your RV outflow tract and your aortic valve right here, and you can see the defect right here kind of going in between. It's very close to both of your semilunar valves. Muscular VSDs are, again, muscular septum is the majority of the ventricular septum. They can come in isolation or in multiples, and if you see multiple different muscular VSDs, we call that a Swiss cheese septum. Again, they can be found in childhood, and they often also close spontaneously, but if closure is indicated later in life, they can be closed percutaneously with muscular VSD occluders. They can also be closed surgically, also in the spectrum of other surgeries. I will say that we see muscular VSDs, and most of the muscular VSDs that we close are going to be often actually post-MI VSDs, more in the acquired heart disease population. But we occasionally will see a muscular VSD in an adult where we think that it's implicated in left heart dilation and talk about closing it percutaneously. And these are a few images of that. This is a post-MI patient from last year who had a large heart attack that caused actually necrosis of the muscular ventricular septum. And in this LV angiogram, you can see that there's flow going from the chamber on the left, the patient's left, going into the right. This patient's very sick. They also have a transvenous pacer and a balloon pump, just to give another imaging modality. Finally, I'm not going to speak too much about AVSDs because you have a whole 15 minutes coming up about it, but the inlet ventricular septal defect is the fourth variety, and it is part of that endocardial Cushing AVSD constellation. But just like mentioned when we were talking about primum ASDs, it's associated with primum ASDs and the AV valve abnormalities. One thing I will say about inlet VSDs are just like when you think membranous VSDs, you think about tricuspid regurg, and when you think about outlet VSDs, you worry about aortic regurg. If you see inlet VSD, you think about AV nodal abnormalities and fascicular block problems and things like that, in addition to AV valve issues. So the management of VSDs, well, it's dictated by age, by the defect size, by the vascular resistance. As I mentioned, a lot close on their own. And when do we consider closure? Well, if you're seeing moderate to large defects, if the QPQS is greater than 1.5 to 1, we do consider have a lower threshold for inlet and outlet VSDs, especially if they're developing aortic regurgitation. And when do you not close, which is sometimes just as important as when do you close, is if you really have significant pulmonary hypertension. If it's fixed, certainly you don't want to close, and if it's getting to the high points, you don't want to close as well. So just to give a couple of different scenarios, like you have a symptomatic young infant with early pulmonary high PA pressures, you would consider closing, doing surgery within 3 months, and that's incredibly important to prevent the development of pulmonary hypertension. An asymptomatic patient who is doesn't have pulmonary hypertension, but you're starting to see left atrial and LV volume overload, well, you would consider closing surgically to avoid late LV dysfunction. An asymptomatic patient, which is often what we see with a small restrictive VSD and not really much LV dilatation, you probably just do nothing and watch over time and repeat serial imaging and have them come in from a clinical evaluation and make sure that nothing is changing. But going to the last one, if you have severe pulmonary hypertension, again, or Eisenmanger's physiology, absolutely do not close the VSD if you really are shunting right to left consistently, because you may actually change the prognosis of the patient to a worse prognosis. Having the VSD may actually be protective in their long-term outcomes. So the guidelines, which from ACHD, which just got updated this past year, they say that you should consider, it's a 1B indication to close if you have LV volume overload with a QPQS of greater than 1.5 to 1, and if the PA pressures if you don't have pulmonary hypertension, essentially. Similarly, if you see worsening aortic regurgitation, they recommend closing. And if you've had a history of endocarditis, which is an increased risk of with having a VSD, they consider closing. They actually leave a little bit of openness as a class 2B indication to close if you see high PA pressures, if the overall direction of the shunt is still left to right. And as I mentioned, surgery is an excellent outcomes in closing the VSDs. Operative mortality is low, and it usually involves direct patch closure with cardiopulmonary bypass. And if you look at the long-term outcomes after surgery, there's really, patients do extremely well. There's no difference in survival, 15 years, compared to age-matched controls in patients who've had VSD closure repair. I will mention as a, I guess another disclosure as an interventionalist in part, percutaneous device closure is something that we do and can offer in the right patients. I mentioned muscular ventricular septal defects. We often talk about closing those percutaneously. There is no device for perimembranous defects, so there's been a device that's been studied with good outcomes that hasn't made it to the market yet, called the perimembranous VSD occlusure 2. But we, for that patient that I showed you earlier, that, we put in and we closed the muscular VSD that had developed post-MI. And there are occasional membranous VSDs that we close. This is someone who had a ventricular septal aneurysm and a membranous VSD that was closed percutaneously. And so these can be done. As far as endocarditis prophylaxis, just to, in the last 30 seconds about VSDs, we, in general, other than if you have a residual shunt with prosthetic material or within the first 6 months after repair, we don't generally recommend endocarditis prophylaxis with the presence of a VSD, which might be a little bit different than what a lot of the patients were taught when they were children. I don't usually fight that power so much because it's really such a lot of patients feel more comfortable with it, but it's not a necessary thing to engage if they don't have a prosthetic material and the VSD's been there for a while. Last 2 minutes, patent ductus arteriosus. So PDAs are a normal connection between the aorta and the pulmonary artery that continue to be persistently patent in about 0.5% of term infants. There is a female predominance, and there are environmental risk factors that predispose you to a PDA, such as maternal rubella. Now, most PDAs, after you're born, with changes in respiration, will close within 48 hours after birth, but occasionally they do not. And the clinical symptoms that can develop after a PDA range and depend upon the size and the shape of the PDA, in addition to the same issues of vascular resistance between silent and asymptomatic, some that you hear a murmur or you just pick up on echo, others that you get some mild exertional intolerance, all the way to the large shunts that cause left heart dilatation and pulmonary hypertension. And just similar to VSDs, there is an increased prevalence of endocarditis with the presence of a PDA than in the absence of one. As far as going to the symptoms and the ways they're picked up, I mentioned that in childhood, a large PDA may present with congestive heart failure. You don't usually see that in adulthood. If it's large enough to have done that by that point, then you've probably developed pulmonary hypertension at that stage. But they're sometimes picked up, even small to medium ones, with patients coming in with palpitations. Certainly by imaging modalities, we image patients more and more often, and so we often see issues like that where you just kind of pick one up incidentally, have to decide what to do with it. A widened pulse pressure akin to aortic regurgitation, and the classical physical exam finding of a continuous machine-like murmur. Now, if a PDA becomes severe PH and you develop pulmonary hypertension, you can get reversal of flow where you go right to left across the PDA. That allows deoxygenated blood to go predominantly to your lower extremities. And then what you see, such as in this picture, is this kind of pathognomonic finding of differential cyanosis, where you have normal SATs and normal and lack of acyanosis in your fingers, but you get clubbing and cyanosis in your toes, and which is why in any patient where you're suspecting a PDA, you want to check SATs on both their feet and their hands and examine both their feet and their hands carefully. On echo, this is an example of a PDA. We see it often in parasternal short axis views or kind of above the sternal views. And this is an example of a flow from aorta to the PA. Again, reasons to close, we already touched on this, are if you see evidence of left heart dilation and you don't have pulmonary hypertension, or even if you have a net left to right shunt and with high PA pressures, you would consider closing, but you don't close if you have fixed pulmonary hypertension with right to left shunting. I left prior endocarditis on there because I think a lot of us, even though that fell off the guidelines this year, for those of you who may not know, I think if you've had multiple bouts of endocarditis and you have a PDA, most of us would still recommend closing the PDA because really, whether it's surgery or interventional, and a lot of PDAs are closed interventionally, the risks are pretty low and it's a relatively safe procedure. This is an example of a percutaneous closure of a PDA, which can be done quite safely. So to conclude, VSDs and PDA physiology, it's largely dictated by defect size and relative vascular resistance. The spectrum of clinical presentation ranges from asymptomatic all the way to the spectrum of severe pulmonary hypertension and heart failure. Echo is a primary modality for diagnosis, though MRI and cath have a role. And surgery and percutaneous solutions are available to close the physiologically appropriate VSDs and the majority of PDAs when indicated. So thanks very much, everybody.